Thank you very much to the organisers for inviting me today. It's a pleasure to be with you. Hopefully you can hear me well. I will share the screen and be with you now. So this is my talk, and as you can see, my Twitter handle at the bottom. I'd encourage people to get onto the social media and follow the Gerionc hashtag. It's a fabulous way of interacting with the world of geriatric oncology and feeling part of the family. This is my disclosure slides. I do a number of paid work for pharmaceutical companies, but the majority of my income is derived from the Government of Australia. This is the Albury-Wodonga Regional Cancer Centre, completed in 2016. And we service a catchment of patients from regional Australia. I'm going to be doing a bit of talking today about clinical trials data, of course, fairly dry, unfortunately, but what we're also concentrating on is the real world and some real world data. Of course, our older adults are more representative of the real world rather than the clinical trials. And as part of the real world in Australia, you can see that the median age of diagnosis of cancers is largely older people. These are a lot of common cancers that we see. And in Australia, the median age of diagnosis of melanoma is 66. Lung cancer 71, bladder cancer 76, and cancer of unknown primary is 78 years. So as you can see, with the median age of diagnosis of cancer in Australia at 68.4 years, cancer in older people is a major problem here. Where do I fit in? Where do I currently work? This is an opportunity to show that there's a map of Australia, for example, showing the incidence of melanoma, which you can see is more in the north of the country. I live and work in the southeast in Albury-Wodonga. I'm in a practice where we map our data, and we have 17,000 patients which to map. And this is an interesting way of looking at it. This is the patients, as we can see, the average age on the bottom axis, up to 75 here, and this is the number of years that they've survived if they've died from their tumours. And the size of the sphere, if you like, is the number of patients that we've seen. And as you can see, our younger patients with brain tumours are down here, poorer survival and younger, and yet bladder cancer and cancer of unknown primary and lung cancers, some of the patients we're talking about today, have a poorer survival and tend to be older. In researching this talk, I looked at real world data and found, of course, that you are completely ahead of us, and you've published your experience in immune checkpoint inhibitors. And it was interesting for me to see the age breakdown, the patients that you've treated and the drugs that you've used. And it was intriguing to me to see that melanoma, which unfortunately is a fair feature of my talk today, isn't included in the cutaneous melanoma section, and I presume it's a relatively rare condition in your country, but not so here, unfortunately. So let's talk about our case to ground us. This is Mr. IH. He's 89, and he had a metastatic melanoma on the sole of his foot. He had noticed lymphadenopathy when he was 87 and commenced single-agent pembrolizumab at that point. He was in complete remission on FDG-PET after 4 cycles, continued treatment without toxicity. In August of 2017, when I wrote this, he presented to his GP with high glucose, and it was ketoacidotic, requiring an insulin infusion. So he had immune checkpoint inhibitor-induced type 1 diabetes mellitus. It's not regular type 1, it is a distinct entity, but as you'll be seeing, it's more difficult to deal with. He says, very philosophically, look, I'm alive, my cancer's gone away, I don't mind injecting myself 4 times a day, and off he went with his insulin. He didn't restart his immunotherapy, and he got back to playing golf, but he faced ongoing issues. The diabetes from this is very brittle, very difficult to control. Only was, and we're talking about wearables just now, it's only really achievable using a wearable sensor with flash glucose monitoring. And even in Australia, that's difficult to access a lot of times. So it's a lot of difficulties, but it did improve his care. He became more frail, And 2 years after ceasing his treatment, he developed a hemianopia and developed a stroke. This was the MRI, as you can see, an occipital issue. He didn't recover from this. His vision never returned. He was unable to read, significantly disabled from this episode. We didn't confirm disease at that point, but then when he was at 91, he became more delirious, and an MRI repeated at that time, which I don't show you, as a solitary brain metastasis. We did do an FDG PET, which showed small volume lymphadenopathy. So at that time, we thought, well, do we give him with more immunotherapy or not? Really, to channel Enrique Soto's work, there was really no hope for recovery of independence in this man. We opted for no treatment, and palliative care alone, and he died aged 92 in November of that same year. So immunotherapy in older adults with cancer. What's the rationale for treatment? I'm not going to go through this slide. I just really want to highlight the fact that these are the names of the drugs that we're talking about. And also these are the indications. Certainly in Australia, it's ever-growing indications. There's 3 slides of them now. Skin cancer, which is melanoma, cutaneous squamous cell carcinoma, Merkel cell carcinoma, the non-small cell lung cancer, which of course I'm sure you're all using, in various settings. Combination ipi-nivo plus chemotherapy, single agent development after potentially curative chemoradiotherapy. We're using it in patients with small cell lung cancer now, of course. We're using it in genitourinary cancer in a number of settings, kidney cancer, bladder cancer. Of course, the patients just with MSI high tumours, phase 3 evidence for that. Certainly using that. Esophagogastric cancer recently. Gynae cancers, mesothelioma, as you can see, a long list of indications ever growing. We can see that in FDA applications. This is a paper from 2021 showing the number of FDA approvals for this is growing with or without biomarkers. If we go back in time to the original, using melanoma as the case discussion, we can say it really has been a game changer since then. I'm highlighting this to show some of the data within the trials. These are the trials that introduced us, of course, to waterfall plots and swimmer plots and the important plateaus of the curves, a new way of looking at data. The median age in this studies were not too bad, all things considered. When you look at the age ranges, are relatively high. So this is one of the seminal studies of ipi-nivo versus nivo. So the median age in patients with melanoma wasn't too bad. We also saw that the toxicity list was long, and as we know, it still is. And in this particular case, the combination ipi-3 nivo 1, more grade 3/4 toxicity as you'd expect in the combination. However, with that toxicity comes improvements in survival, and still ipi-nivo is still, as we said, the combination is standard of care in patients with melanoma. In patients with non-small cell lung cancer, of course, this was the other seminal study, Keynote 24, showing that single-agent pembrolizumab improved survival and toxicity in comparison with chemotherapy in patients with a PD-L1 level in the tumour greater than 50%. Now, the median age of this group, less, 64, so that's about 7 years under the median age of certainly patients with lung cancer in Australia. So not surprising, this is more a select group. But despite that, there were still some older patients within it. The 5-year follow-up from this study shows that the survival improvement still is lingering, and from ESMO Virtual Congress, as you all know, from last year. Toxicity, as you also know, is different between chemotherapy and immunotherapy and is generally more favourable, but it is different and not insignificant. Now, what about immunotherapy in older adults with cancer? As we've heard already, is it as effective? What about immunosenescence? Well, essentially, the data suggested from a number of sources that it is as effective. There's a Danish population study from patients with metastatic melanoma showing it's effective. And whichever way you look at it, subset analyses, meta-analyses, real-world data, the studies that Ravi has presented earlier, which are not in this talk, so well done for complimentary talking there, Ravi. No evidence of decreased effect. So But is the toxicity worse? Another example from my practice, a man with metastatic melanoma, 72, he presented, so he had an FDG PET after commencement of his pembrolizumab, showed that he was in remission, but also, as you can see, every joint in his body lit up like, in Australia we say, a Christmas tree. So here he is, he's got widespread, and it's crippling him. He's widespread arthritic changes, generally inflammatory arthritis after only a few doses of pembrolizumab as a single agent. So what I did then was gave him 10 milligrams of prednisolone a day and repeated the PET scan after more treatments because he actually wanted to have more treatment. And we showed that he was still in remission and everything settled down. He got his life back, but he's on prednisolone. So what do we do when we're treating patients with immunotherapy in older adults with immunotherapy? And this, of course, is one of our favourite diagrams from one of Dr. Soto's publications. Strongly recommend it. What happens when we give immunotherapy to an older adult with cancer, given that we can essentially give toxicity to any part of the human body, as you know? And I'd also recommend still this article from many years ago about what the toxicities of immunotherapy are. Manage them. We know ipilimumab causes toxicity. We know the PD-L1s cause toxicity, what they commonly are, and when they occur. Is it worse in older adults with cancer? Well, it's complex. So here we have a retrospective analysis of patients, once again with melanoma, 254, showing that it's tolerable, as we know. Survival outcomes are the same. But here we have the toxicities, and not insignificant, but not significantly different in many things, apart from maybe arthritis. But then it was better in our older adults. So we know they get toxicity. Is it different? It's tricky. Immunotherapy in this study was given to patients over the age of 80, so age 80 and 90, once again showing it was useful, and there was mild toxicities, and patients who are in the older age group this time had more steroid treatment. As they did in this prospective study from Fabio Gomez recently published, showing that in patients with non-small cell lung cancer and melanoma, single agent immunotherapy, with age distribution between less than 70, over 70, there was no difference in immune-related adverse events, but the exposure to systemic steroids due to the immune-related adverse events was numerically longer, although not significantly longer. In this study, they did a G8 screening tool, so it's starting to see integration of geriatric assessment in some way into these studies. A positive G8 screening tool predicted hospital admissions and death. These are the toxicities in Fabio's trial, showing the cumulative toxicities were not significantly different. And where the toxicities were also not different between the two age groups. No surprises, really. G8 was used looking at functional status, and as you can see, predicted for adverse outcomes. Dr. de Glass, in a larger study of patients with melanoma from a Dutch registry, 2,000 patients over the age of 65, showed that treatments are changing. So we can say we're getting slightly more combination therapy as we become more used to using these treatments, and data suggests that it's important to use in patients with melanoma. And then she looked at other things like toxicity, found that combination treatment was prescribed less, but still prescribed. And age was not a predictor of response to therapy. Excuse me. There was no increase in grade 3 toxicity in older adults. And older patients did receive fewer cycles, possibly due to that lower grade, so the higher grade 1 and 2 toxicity, or should I say, the presence of grade 1 and 2 toxicity in a patient who may be more prone. Recently, we saw Carolyn Presley and Andrew Johns look at 238 patients over the age of 70 with advanced cancer. As you can see there, melanoma and non-small cell lung cancer with combination or single agent therapy. And they saw that there was improved survival in the younger patients who had more grade 3 toxicity, but not in older patients, as we can see here. So that's about the only times we've seen a differential in improvement survival in age, depending on toxicity. So hypothesis generating retrospective work, but that's what they show. Can we prevent toxicity? Well, young COG are leading the way here. They've got a couple of studies looking at immunotherapy in older adults. This first one from non-small cell lung cancer, looking at the phenomena we talked about, doing geriatric assessments to try and see the impact of lower-grade toxicities. Once again, Enrico's name is on this one from the patients with melanoma, saying we should do a geriatric assessment, as we all know, as part of the algorithm, and then try to say, well, can we give more frail patients single agent perhaps, or non-frail patients combination possibly. So incorporating this into the algorithm is important. I'll say that the NCCN, however, say that you really shouldn't reduce the dose. As I said earlier, there's a Ipi-Nivo combination where you've got higher dose Ipi-Nivo and lower dose nivolumab in patients with melanoma. They're saying giving a lower dose of that is currently not advised to avoid toxicity because of the like we don't know the data on its effect on survival. And what about single agent versus combination melanoma for patients with melanoma? There are a few things that the experts can look at apart from frailty, such as the BRAF mutation type, such as the volume of disease and so on. There are toxicity management algorithms that, of course, are important, and the ESMO article points to that. General principles, of course, you can't just reduce the dose and hope that everything's okay, really. Management does depend on the toxicity, so you'll manage pneumonitis differently from the thyroid dysfunction, but you have to grade the toxicity, use the management algorithm, and sometimes, as I said with my patient, you continue low-dose immunosuppression and continue the immunotherapy. There are guidelines from MASK, which I'm sure many of you know of or are members of. If not, you should be, as well as SIOG. So MASK and the National Association for Supportive Care in Cancer have this publication recently. Once again, algorithms with defined management plans, depending on the grade of the toxicity, for important things like hepatitis, pneumonitis. I'm sure you're all aware of those. And as it comes to older adults, of course, frailty is the key here. This is why you do a geriatric assessment. If you're pushing someone to become dependent because of their frailty, you need to think twice or support them through that journey, but do the assessment to determine their level of frailty. Just guess. Geriatric assessment prior to treatment, guide supportive care. We don't see an increase in toxicity really with our patients, but our patients may be unable to cope with even the lower grade toxicities because of their age and other comorbidities. They're more vulnerable to side effects of immunosuppression, such as low-dose steroids. Proximal myopathy is an enemy of mine at the moment. What are the role of steroid-sparing agents if they do need long-term steroids? And this is where the rheumatologists are working with us here. They're beating us to our own game. They're saying, oh, hang on, why don't you the paradigm shift for patients with immune-related adverse events? Why don't we use some DMARDs instead? Let's turn the steroids first on the head. So I think we've got lots of studies to do in this space with our rheumatology colleagues. There's some names of drugs which we should be able to know and recognise, not just their effects on patients with cytokine storms, that's COVID-19. So my final slide is immunotherapy in older adults seems to work. There's no evidence of increased toxicity really, but older adults may be more sensitive to adverse events and side effects of immunosuppression. And as usual, geriatric assessment yields, guides appropriate care and helps us to get the balance right. Thank you.
Thank you, Dr. Steer. That was a very comprehensive assessment of immunotherapy for older adults. Are there any questions from the audience?
Yeah. Thank you, sir, for so comprehensive presentation. Sir, I just want to know, in elderly, do we have to monitor these patients more frequently for adverse events as in the normal population, or it should be the same? As we see the less functional reserve and chance of immune toxicity slightly more, as you said.
Yes, well, we should always be doing the geriatric assessment first to try and enhance your supportive care and look for those problems. But yes, more monitoring, it's a question that I guess has not been studied in trials to look for frequency. I must say, however, when I'm giving patients, considering giving them 6 weekly or pembrolizumab or 4 weekly nivolumab, I'm uncomfortable because I started giving this fortnightly and then 3 weekly and then bringing them back down, and I saw problems in the first visit. So if I give someone maybe a 6 weekly due to COVID-19 because you want to get them out of the hospital, for example, I'll do a telehealth consultation or get some blood tests 3 weekly. But that's across the board, to be honest, regardless of age. So should we be looking after our older patients more commonly? Well, if you follow the argument that low-grade toxicity is common and can be more impactful, then you might say yes. But I think that's there's no data behind.
Yeah, so for like this 6 weekly regime, so we should do these hormonal tests, what we do the LH, FSH, ACTH and other thyroid functions before every cycle, or it's the usual parameter which we are following that initially every 3 monthly or so?
We don't really know, but I find blood tests pretty easy to do, and you can get surprises, especially with things like liver function abnormality and kidney ones. They can just creep up on you, and so absolutely basic blood tests, thyroid, of course, it's important sometimes, cortisol, etc. But yeah, we fit it into a routine, and certainly where we are, it's before every treatment. Sometimes you'll proceed without getting all of the results back, but yeah, blood tests are routine monitoring because of the surprises that you can get, such as hepatotoxicity.
Thank you, sir.
I think Dr. Akhil, you had a point to make. Please go ahead.
Yeah, so as pointed out with Christopher sir as well, that further checkpoint inhibitor trials, it is expected and encouraged to incorporate at least some form of geriatric assessment so that we can have some better idea about the toxicities in these patients, because this is actually a data-free zone. We don't have data how these patients are going to behave, and we don't have any mechanism to suggest which one will develop toxicity or which one will not. So I think if we can incorporate at least some form of geriatric assessment, if not the CGA, some form of screening tools, that will help us getting more and more idea. Sir, your comments on the same?
So thank you for that. Yes, so Fabio Gomez's work, which has recently been published, looked at the G8, 8 questions. It's interesting because I do it in my own clinic, and you have to ask the patients things like, what is your self-rated health, and compared with other people, how do you feel, your health status is, and otherwise it's derived from the mini nutritional assessment, which is very diet-based. The teams in America, I know, are using the G8 with an IADL, so the IADLs as well. So there's various ways of doing it, but that's a simple screening one, which, as Fabio has shown, can help predict hospitalisation and death. So there's a simple screening one if you don't want to continue to the other aspects. But interesting with immunotherapy, as you notice, I didn't talk about a toxicity prediction tool like we have with chemotherapy and Arti Huria's tool. So that, and you can probably see why, it's really hard to predict. The toxicity rate is lower, and it could be anything. So, and I took some slides out from which talk about giving immunotherapy to people with pre-existing autoimmune diseases. We know that that's safe in some, but you're possibly more likely to get your rash than if you've got psoriasis. But that's another area of further work. So how do you predict the toxicity? Tricky, ongoing resort. But in general, if you're going to look at the whole person and you're older adult with cancer, then you should do some form of geriatric assessment. The G8 screen is not a bad start, but you can do more.
Thank you.
Thank you, Dr. Steele. I was actually going to ask you about the toxicity risk prediction tool, but I think you answered that just now. So we don't have one, right? For either for targeted agents or for immunotherapy for older adults.
That's right. It's patients over the age of 65 commencing chemotherapy. There's a recent one for patients with breast cancer, which was like a different module, but not for immunotherapy or targeted therapy.
Can I ask a question?
Yes.
So about experience in managing the toxicities in a steroid-sparing manner. about use of other the DMARDs or the other immune suppressive agents. So can you share your experience about that?
Yeah, certainly, and I'm sure that you probably have similar experiences where you are, where in the beginning a team approach was thought to be best, where you involve all the other clinicians, endocrinologists, respiratory, gastroenterology, hepatology, rheumatology. As you become better at doing it, picking it up yourself and managing it, knowing what they do, then of course oncologists are becoming more used to doing it themselves. However, there's a few things like the long-term rheumatological conditions and managing methotrexate are difficult. I've got a number of patients on weekly methotrexate or co-managed with the rheumatologist. But the really lethal ones, the pneumonitis and the hepatitis, you usually engage your colleagues with that, especially one or two patients died from pneumonitis. Major challenge, and you run through we don't have access to the DMARDs here. You've got to do a case by case. It's just even for infliximab for your patients with diarrhea, which is a major challenge. Luckily, it doesn't happen all that often. We have certainly moved to using them more quickly if we can, though. But in terms of getting access to the drugs and putting them right up front, apart from just giving a slug of methylprednisolone, we're not there yet. I'm certainly in my patients with hepatitis over bringing forward steroid-sparing agents. Yeah, we're getting better at it. It's still a team effort for some situations, but funding for medications is an issue even here.